May we then move on to agenda item 11 on patient insight work. We don't have a paper for this, but I'm going to invite Tim to give us an oral presentation.
So we've, at various previous meetings, identified, I hope correctly, that participation is fundamental to the success of the commissioning board and the NHS as a whole. And we have, in parallel, been embarked on a series of really very rich collaborations with both individual patients and with patient organisations to think very differently about how we can genuinely build the patient voice into the heart of our planning and of our delivery as we get to that point from April. And I mean, broadly put, we're not doing enough. We are. What's been great has been the response from the community at large, who really do want to take this opportunity and build a very different kind of partnership between this organisation and the patient community. But we've got a long way to go to genuinely, honestly be building the patient voice into the way we are operating. I think we've made a really good start, but we should be, I mean, far from complacent. So just to give a sense and some thanks up front, we've had, I've been involved in various workshops with organised by the NHS Alliance and National Voice and various other organisations, patient associations, which are beginning to, I think, draw a really clear vision for us of how we can do better in putting the patient voice at the heart of our own thinking. And I would like to bring to this board proposals for a kind of an emerging concept of a civil society network, something which will hold us to account strategically as we move forward. And we've been co-designing that with the patient advocate community, and I think that you know, if the board is approving, could be a very rich and an innovative new way of trying to build a kind of continuous relationship with our customers, put bluntly. So apart from that kind of development of strategic partnerships, and I should also say that Healthwatch we've been working closely and will continue to work closely with Healthwatch as it develops, so that we end up with being able to pool insights across the system, again, so that we can, as a system, develop, not just as an organisation, in line with our core aspiration to prioritise the patient in every decision we make. The second part of this, on the one hand, there's strategic engagement and voice, is simply to embed that in the day-to-day workings of the board itself. And Ian has just mentioned ways in which we have tried to build a patient voice into, for example, specialised commissioning, but our burden is almost greater than anyone else's. You know, we have to be more than exemplary in doing that for real and avoid any possible perception that we're merely token in relation to the engagement with the patient and citizen at large. So I'm going to be working really closely with colleagues in specialised commissioning and indeed in direct primary care provision to make sure that we think very differently and innovatively about building that in, so that we can hold ourselves up as a hopefully supportive example to colleagues in the CCG and other communities to challenge their own thinking about how best we can achieve this vision of kind of engaged, participative healthcare. So that's on the one hand, that was an update. On the other, I just wanted to very, very briefly touch on, equally importantly, the sort of insight coming in real time, routinely, from all of us in relation to the services we receive. So in a sense, we have a kind of a strategic day-to-day voice that we need to put at the heart of the way we think, but equally we need to have just loads of data coming from us as citizens and patients, informing the way we go about thinking about outcomes, obviously. And at the moment, that data is very, very sparse. We run surveys, we have responsibility for annual surveys, but you know, we shouldn't kid ourselves that we operate in a fairly fundamental vacuum of insight into actually how patients are experiencing the services they receive. And we have a mountain to climb to get to be, I hope, an absolutely world-class exemplar of how you can indeed generate that kind of data and put it to use in clinical contexts. So just one example of something that I think will become a big kind of flagship for us. We take responsibility for deployment of something called the Friends and Family Test from April. Now, the Friends and Family Test has a very well-proven track record in other industries. It is simply asking people at the point at which they receive your service, would they recommend that to a friend or family a member. And we know it works. It works brilliantly well in lots of other contexts, and indeed also in healthcare. There are good examples both here and in other countries of ways in which that particular very simple real-time question has in its aggregation provided immensely valuable business intelligence back to the provider of the service. And just to give you a sense of the scale at which we are going to deploy this, by April, by the time we actually go live, we will be publishing routine data on the degree to which patients are recommending a local service in all A&E departments in England and in all overnight inpatient contexts. So that in itself will be a very big indicator and hopefully exemplar of the way in which we can start putting the patient voice very, very, very transparently at the heart of our commissioning. By October 2013, we will have rolled this into all maternity services. We think that's a very important area for focus. Parents find it very, very hard to understand just what the quality of the service that they're receiving is, and a crucial part of that is understanding just how it works for other people. So we want them to have that information. And then we will have the responsibility, and again I'll bring proposals in due course for how we will take that measure, the Friends and Family Test measure, but equally other kinds of insight measures and roll them out across all of the care context, including social care context that we are commissioning for our patients. And then a lot of sort of the third kind of part of this update really is around the importance of having generated that data and indeed other kinds of data to support our credibility as an organisation commissioning against outcomes. We need that data to be transparently available and accessible to people. So another very important piece of work, which actually we have made a very good start on, is just to get the data out there so that people, us included, clinicians, patients, can use it easily to deduce things about the quality of services that are being received. So we have very immediate plans for publishing data on clinical audit in primary care. You'll see the board will see that in the context of the planning guidance that we've been working on coming forward. And then finally, just to sum up, the importance of all this information isn't just to, and patient insight isn't just to drive clinical decisions. It's also, I think, much more broadly also part of our responsibility to be driving innovation and growth in things like the future of medicine, in research, and in technology. And I think that this, if we can turn, as we will, the health and social care system into a data-rich environment, that will not only massively support patient outcomes, but equally, I think, support Britain's place in the world as a driver of important clinical and other types of research and life sciences in particular. What I'd like to propose on the back of this conversation, after the board was interested, would be that I develop a routine paper for future board meetings, which proposes some metrics by which we can hold ourselves to account for actually meeting the critical success factor 12, which is genuinely not so much how have we demonstrated that patients in the public feel they've been engaged, but actually how have they been engaged and what has been their response. So I'd like the board in a way to set me the challenge of going away thinking about what sorts of measures would be fair to hold ourselves to account for having done that, and then to report that back routinely to the board in subsequent meetings.
Thank you very much. I suppose I should declare an interest as a Vice Chancellor of the University in the last comments that you were making about the way in which the NHS can far better interact with life sciences and with research in this country and make a truly global contribution. So warmly endorse everything that you've said, Tim. Comments from colleagues? Yes, Victor.
I think that's very, very good for it. I just think I'm interested in to what extent we can use the specification for what you're going to do to give us insight and knowledge into those people that are at the sharp end of the inverse care log who've got this duty around inequality. And I just wondered, when you think about this, when you design your dashboard, that might be something that we could know about. And also I'm interested in the risk in some of the areas that you're looking into, that we get information, insight from those people who can talk to us, but not from those people that we need to hear from. And I just wondered about how we mitigate against that.
being in the retail industry, I couldn't endorse more wholeheartedly any system that involves metrics based on actually asking customers what they want. Makes eminent sense. I think that it obviously shouldn't just be patient focused, but also carer focused to get full width of responses, and then picking up on what Victor said, which is critical. That the number of people who respond vociferously should not be the point at which we rest. It should also be on those people, or focusing on those people who ought to be heard. And that's going to be a hard ask for you, but that is critical to make the data meaningful.
Well, and just to cover that point off quickly, I mean, what we, in talking to partners out there and just thinking ourselves about how we can try and rethink the nature of the way we engage with our customers, carers, patients. I am very attracted to the idea of building a very, very comprehensive network so that the advocate community is able to speak to us, but not just the advocate community. We try and encourage as many voices as possible, alongside, as I've sort of said, that capturing everybody's view in a routine way, in a context that you clearly know is market research, which we've been very poor on in health service. We just have not done adequate market research, and so these are tools which are very common in other contexts, and we to some extent just need to import them appropriately into the health and social care system. But those comments are really helpful, and I'll build those in.
Tim, can I just ask something I should know? I've kind of lost the thing. But can you, the friends and family ambition for the 1st of April, who's actually going to do it?
So we are currently project managing on behalf of the Department of Health, so that there is a clean transition in April to us as the responsible party. So at the moment, the Department of Health remains the accountable SRO officer for Friends and Families. So we have taken on the job of its delivery.
But for it to start on the 1st of April, who's doing it?
Which actual team is doing it?
No, are there people in hospitals, or are they in the local area teams doing it? Are they?
So at the moment, the SHAs are working with all their local hospitals. There are teams within each SHA who are tasking, who are monitoring progress with hospitals. Okay. And I'm not for 1 second suggesting it's an easy task, but there is quite a significant program of work going on to ensure that we do get compliance with the April 1st requirement.
The guide pilot has been piloted in Midlands and East because they had an ambition that they set there, and Midlands and East.
In A&E?
No, in Midlands and East in hospitals.
Yeah, but in A&E. Don't think they have.
Don't think they've done A&E, but they've written the guidance.
Okay, we'll check it out. They're just
good, right. Tim, thank you very much for that presentation. I propose that we should move on to the next item, which is finance.
I've nothing to add to the report, which confirms essentially the picture I reported last month, that we are slightly underspending year to date, but anticipate using our funds and no more by the end of the year.
Good, thank you very much. Item 13 has proposed a brief feedback from Ed and Victor, if they wish to. Ed, in relation to Finance and Procurement Committee?
No, nothing from me for this meeting.
Victor, in relation to CCG Committee?
Me and the group here are immersing ourselves into the dark waters of CCG approval and commissioning process.
Excellent, right, thank you. My only item of other business is to report that the next meeting will be on the 14th of December. Location as yet undecided, following further discussions we've had today. Could I just, before closing the meeting, express, on behalf of all the board, our gratitude to the national directors. This is really hard work, and we appreciate that. We, the non-executives, stand alongside you. I mean, we're here to challenge, we're here to learn, we're here to assure ourselves in the proper conduct of the business of the board that we've understood the risks, that we've understood the strategies, both for delivery and for risk mitigation, and that we have, I think, started fully to understand the scale of the enterprise upon which we're all embarked. and the enormous volume of work and decision making that needs to be taking place before March next year. But thank you for the clarity of the reporting today and for the work that we've been doing together. I declare the meeting closed.
Thank you.
But I'd very much like to invite members of the public to join us outside in the coffee area for some refreshment.